as we are looking into the autonomic nervous system, let's first kind of talk about where we have been. So we went through the somatic sensory information where we talked about the sensory neurons that are going to carry information from the periphery towards the central nervous system. And then remember, we also have the visceral sensory that will carry anything from our internal organs, of course, from the periphery to the central nervous system. We then went through the somatic motor, which tells us, okay, we need an upper motor neuron and a lower motor neuron in order for us to innervate skeletal muscle. So this is what today is all about. Today we're going to be going through the visceral motor division, so specifically the autonomic nervous system, so that we can innervate all of the organs inside of our body. Whenever we're looking at this particular chapter, we're going to be talking about things that are going to operate without conscious instruction. So in the past, I've said conscious and subconscious in various situations and different pathways, but this is going to be unconscious, okay? So you have no idea whatsoever that this is going to be going on. And all of this is to control what we refer to as visceral effectors, okay? Visceral effectors, so those organs that can then make a change in order for us to, of course, maintain homeostasis, because that's what this is all about. So all of those visceral effectors are going to be in different systems like cardiovascular, respiratory, digestive, urinary, and reproductive. And this can adjust internal water, electrolyte, nutrient, and dissolved gas concentrations in the body fluids. Okay? So remember, all to maintain homeostasis without our awareness and keep our organs healthy and well, so that in turn our blood is healthy and well, our cells are healthy and well, everything is functioning as it's supposed to. So with this little chart right here, what you can see is, again, we've gone through all of this information, and today's focus is going to be the peripheral nervous system, the efferent division, specifically the ANS. So remember, our ANS will break down into a sympathetic division and a parasympathetic division. So today we're basically just going to introduce the sympathetic and parasympathetic and kind of how they work. Next class is going to be specifically for parasympathetic, and then the class after that will be specifically for sympathetic, okay? So parasympathetic will come first, sympathetic will come second, but today is just kind of like a general overview. So whenever we're looking at our two different systems, as you can see, the two systems differ not only in the effector, but also in their descending pathway and the response. So we're going to see something different today. It's not going to be upper motor neuron, lower motor neuron, and that's where there's some important things that you want to make sure that you look at and that you address in your memory bank, so that way you've got it down. Remember, somatic nervous system is voluntary control of skeletal muscles. We've already done that. Autonomic nervous system is going to be our smooth muscles, glands, cardiac muscles, and adipocytes. So all of the things, again, you can't control. You have no ability to do any changes for it. The body has to do it all by itself. And the hypothalamus is going to contain the integrated centers that are going to help with a lot of this control. So the hypothalamus is a very important gland, and we go through the hypothalamus in much greater detail in 2402 because it is talked about in the endocrine system. So our hypothalamus is our connection between the nervous system and the endocrine system, and we'll get more detailed on that, but just keep in mind that this is a very important gland in order for the autonomic system to work appropriately as it's supposed to. The neurons that are contained here would be comparable to our upper motor neurons within the somatic nervous system. The motor neurons of the central nervous system will synapse on the visceral motor neurons in what we call autonomic ganglia. So that term is very important because you will see that the autonomic ganglia are going to be an integral portion of understanding how all of this actually works. So the ganglia, just remember that is a collection of cell bodies. All right. So let's take a look-see at the comparison picture here between the somatic nervous system and the visceral, the autonomic nervous system. So we saw the upper motor neuron and the lower motor neuron. What I want you to really focus your eyes on here is this black motor neuron is going to be, it's a one neuron pathway from the central nervous system out to the periphery, okay? So it's just this one. Once we leave the central nervous system, there's only one neuron. But if you look over here, once we leave the central nervous system, this is a two neuron pathway. And that's because this first one, which we will call the preganglionic neuron, because it comes before the autonomic ganglia, the preganglionic neuron has to synapse inside of this autonomic ganglia. It does not get to go straight to the effector. So this is a two neuron pathway once you leave the CNS in order to get to the effector. So if we call the red one a preganglionic neuron, what do you think we would call the black one? Post, perfect, postganglionic neuron. So that is the answer to the little question that you have down below there. You can write that down. That would be your postganglionic neuron, okay? Each autonomic ganglion functions kind of like the baton handoff zone in a relay race. So if you were a fan of track, whenever you went through high school, you know what the baton race looks like. There has to be somebody that's going to be at a set point to hand off the baton to the next person so they can take it. The person who starts the race is not going to be the same person that finishes the race. So that's kind of like what you see here in this particular setup for our autonomic nervous system. So for those of you who like words, this is basically the word slide for what just happened in the previous picture. Preganglionic neurons are in the brainstem and spinal cord. We would call the axons of those neurons preganglionic fibers. After leaving the central nervous system, they'll synapse on the ganglionic neurons, aka the postganglionic neurons, and then those postganglionic fibers will be the axons that will go into the visceral effector. So again, our two divisions, sympathetic division is also sometimes known as thoracolumbar. So make sure you remember that. Thoracolumbar is going to be associated with the sympathetic division, and that all has to deal with where these neurons are actually going to be leaving the spinal cord, which I'll show you a picture of that in just a minute. Versus the parasympathetic, we would call this the craniosacral. So different locations for them leaving different parts of the spinal cord. The sympathetic division, commonly known as fight or flight, because this is going to be used in emergency situations or in stressful situations, whenever somebody has to have an increase of the adrenaline in order to make the changes that are necessary in order to get them out of that emergency or that stressful situation. So it'll do things like increase the alertness, increase metabolic rate, and then muscular abilities. So if you're in an emergency and you need to run, then you do want more glucose going to your skeletal muscles so that you can pump your legs and pump your arms to get out as fast as possible, which means your heart rate is going to increase, your breath is going to increase. So there's going to be a lot of changes that are going to occur whenever you're in emergency situations. And like I said, we'll go through that more when we talk specifically about the sympathetic. This is just a general overview. And that is opposed to the parasympathetic, which is for rest and digest. So this is going to conserve energy and help maintain that resting metabolic rate. This also helps during repair time, because remember, in order to repair, you need to be sleeping, you need to be resting. So repair is very important. A lot of people who are chronically stressed out, we would call those people in clinical practice, we would say they're sympathetic dominant. That means that they don't know how to go over into the parasympathetic side and switch off their stress response, which is really hurting and deteriorating their body. So we need to have a balance of both of these. It's good to be able to get into sympathetic mode whenever you need to, but what's not good is to stay there constantly. And a lot of Americans who burn the candle at both ends, they don't sleep, they work multiple jobs, they don't eat good food, they're constantly worried about something, they want to climb the ladder, they want to make that corporate success, you know, all of these things, they just keep going and going and going, and they never take a break and never take a time out, which is basically going to hurt them long term. So you do want to maintain good balance between these two, and so we'll be talking about some ways to do that as well. So usually these will have opposing effects. So in the sympathetic division, if something is going to cause an excitation of a particular visceral effector, then the parasympathetic would do the opposite. It would cause inhibition. And usually most people think about it in that way of, well, if this does this, then the other one does the opposite. And so that is good to think about it, but you have to remember they may also work independently, which is important because only one division actually innervates some structures in the body. And I'll show you where the structures are that only get innervation from one division. And then I put an asterisk here, they may work together, with each controlling one stage of a complex process. And where they work together is also sometimes some things that we don't necessarily have all of the answers to. So as we're going through and talking about some things, you have to remember it's not just the sympathetic does this and the parasympathetic does the opposite. Sometimes they may work together, and sometimes if those signals get crossed or things get mixed up, then it can lead us to some situations where we're like, well, why would this happen? Or what would this effect be? And a lot of those things are still why questions because we can't necessarily tease out why those things may occur. So it'll be more clear as we walk through this and you see some of those whys. Just keep in mind, most people only think of this one, but you have to remember there's three. Okay, there's three ways for them to work, not just the one. So here's some of the responses to that increased sympathetic activity. As I mentioned earlier, a couple of these, but make sure that you see that number 3 is reduced digestive and urinary functions. So what this means is, if somebody comes to talk to me and they're telling me that they are constipated, then I'm going to ask some questions and try to figure out what the underlying cause of the constipation is. But I have to keep in mind that anybody who stays in sympathetic mode is more than likely going to have digestive difficulties, including constipation. So that's one of the things that we have to address. Is it can't just be here, take this liquid or take this pill so that you can go poop. Sometimes it's an emotional thing that needs to be addressed that's stressing them out and therefore causing them to stay in a sympathetic mode where you do not do digest, because parasympathetic is for rest and digest. Okay, so the other thing too, activation of sweat glands. Now more than ever, I see more people who have hyperhidrosis, or at least that's the diagnosis that they have given themselves. So the self-diagnosis, hyperhidrosis. And so hyperhidrosis, yes, that is a real thing. Somebody may have excessive sweating, but we have to know that the sweat glands are one of those organs that are only under the influence of the sympathetic nervous system. There's no parasympathetic input to your sweat glands. So that therefore then means that I need to be looking at those other, again, stressful type situations. Are you sweating just whenever you're under stress, or are you sweating all day, every day? And so that can then kind of make a difference in that treatment protocol as well. Responses to increased parasympathetic activity, you can see here decreased metabolic rate, because if you're not doing a lot, if you're resting, then you don't need a lot of work to occur within your cells. So that cellular metabolism does not have to be high if the demand is not there for it. This will be things like decreased heart rate as well. Decreased heart rate is bradycardia. Increased heart rate, tachycardia. If we have decreased blood pressure, we can say that's hypotension. Usually whenever it gets, technically I think textbook would be somewhere like 90 over 60, you would get the diagnosis of hypotension. So just because you're in parasympathetic mode doesn't necessarily mean you're going to be diagnosed with hypotension. So don't get that confused. It just means that your heart rate is going to be lower and slower, okay? Because your body doesn't need as much forceful contractions as whenever you're actually doing something like taking a jog or something like that. So your heart rate will go lower, your blood pressure will go lower as you are more in a rest mode, less stressed. Increased secretion by the salivary and digestive glands, and that is because parasympathetic is all about digestion, and digestion begins in the mouth. So your salivary glands are going to increase, so that way you have more enzymes to help you break down your food. Increased motility and blood flow in the digestive tract, of course, because this is all about digestion. So this is where we need to get some people to get over into parasympathetic mode in order to help them with their digestive difficulties, if that's the underlying issue. And then stimulation of urination and defecation. So here's one of those whys that I was just referencing a minute ago, because oftentimes we think, well, if somebody scares the crap out of me, then no pun intended, but quite literally the crap could come out of me, right? If I'm scared, like if I'm in sympathetic mode in this emergency situation and I see that there is a lot of danger around me, I have seen people who have been in fights and they will take a poop on themselves. Or if somebody scares you and like you come around the corner and they go boo or something like that, and then you pee on yourself because you're so scared. If that is the case, then we have to ask the question, why then, if it's parasympathetic for urination and defecation, why then does that happen whenever people are scared and then they get stressed out? So again, that's one of those things that remains unclear. I did put this little link in here for this PubMed article so that you guys could go and read it. If you do work with any patients who do have some sort of urinary incontinence whenever they are stressed, or digestive difficulties, things of that nature, if that's interesting to you, then you can go and you can read that PubMed article. But the answer to the question is, we don't know. Okay, so textbook though is that parasympathetic is the one that allows you to do the urination and defecation. And what is commonly given as the example is, if you're really stressed out and like, let's say that person who, matter of fact, I just had a patient today who was like, if somebody's in the room, I cannot pee. Like I have to have people out of the room, I have to just relax, or else my pee is not going to come out. And if somebody is in the room, then they're going to have to turn on the water or else I won't be able to pee. Well, that's about normal because that means that she's not relaxing. She's stressed out because somebody is there, and so that's not allowing her to pee. So once she relaxes, then the urethra will then help her body to eliminate that pee because it will relax. So that is where we get into kind of some of the confusion about urination and defecation because people are different. But generally, the urination and defecation is all about parasympathetic activity. You got to relax. All right, what about freeze? So some people also have freeze as a component of their response to various activities, especially in situations where they may be scared. So freeze is oftentimes confused as a part of the sympathetic response because it very often will happen in emergency situations. However, freeze is actually a parasympathetic dominant state. And it's very cool whenever you go and read this article right here. I love this article. This is really, really good information because it talks about how whenever you're in freeze, there's a couple of reasons why as a species we'll go through freeze. And some of that has to do with stopping to figure out, are we going to fight or are we going to flight? So sometimes the freeze is a reaction to, I need to take a few seconds to figure out what to do. Now, unfortunately, sometimes the freeze can put you in further danger. Like the last person we want to freeze in an emergency situation is a police officer. You know, if they have a gun at their face, they need to be able to react quickly without freezing too much, because if they freeze for too long, it only takes a very short amount of time for a bullet to come into their face or wherever they're potentially going to be shot at. So can you train out of freeze? They're trying to figure out. Can you do things that will allow your body to not go into freeze is one of the things that they're currently researching right now, so that those people who do need to be safe on their jobs, first responders, firefighters, police officers, seeing if they can help them get out of this particular problem in those particular situations. But it is noted as a parasympathetic dominant state. So if you look here, this also talks about the brain, the amygdala. Remember, whenever we talked about the amygdala, we were in the limbic system. So the amygdala is going to pick up the signals from the body and identifies the threat, and then you have this cascade of hormones, which we actually talk about in 2402. So the CRH is corticotropin releasing hormone, ACTH is adrenocorticotropic hormone, cortisol, adrenaline, norepinephrine. All of these hormones are going to be released in order to help the body get back into its homeostatic mechanism and either to fight or flight, hopefully not freeze for too long. So it's really cool information in this article about how all of that works together. Now, if we take it a step further, this is where we kind of go beyond the class material, because this is more psychology, this is more trauma victims. If you are going to work with anybody who is going to be a trauma patient, so in any type of situation, there are 4 things that we can talk about in regards to how their nervous system will respond. And I think this information is so fascinating because you will probably be able to look at this chart and read some of these things. And even if you didn't know that somebody experienced some trauma, there may be some things on there that you're like, oh, that makes me think of this particular person. Oh, that makes me think of that particular person. People who have not experienced trauma, whether that's childhood trauma, whether that's fighting overseas in a war, anything of that sort, people who have not experienced that will usually be able to generally balance very well between fight or flight, and they usually will kind of go back and forth between the two depending upon the situation, because they generally know how to pick out pretty well what am I going to actually fight for versus what is best for me to just walk away and leave it alone. However, people who have been in trauma are more likely to do the freeze or the fawn. So the freeze, as you can see here, this is whenever we get into situations like depression, schizophrenia, ADD. The DID is dissociative identity disorder, so multiple personalities disorder. And then the fawn is that person who never wants to say no. They want to make everybody happy, and they are very codependent, very much often are looked at as the victim to certain things, so they don't have the ability to stand up for themselves. So trauma definitely affects our autonomic nervous system. It certainly reacts to our autonomic nervous system in a way that doesn't allow these people to always learn how to get out of situations that they shouldn't be in. So the fawn types are usually those people who are going to stay in domestic abuse situations. The interesting thing is, yesterday one of my students was talking about a 45-year-old that she works with that used to be a bodybuilder, was in great shape, everything was wonderful, but was in a domestic abuse situation and clearly has suffered lots of brain damage and brain injury. She's in a dementia care facility now at 45 years old and is struggling to make it, deteriorating rapidly. So a lot of people who maybe don't understand that would say, well, why would you stay in a domestic abuse situation? Like, why don't you just get up and leave? But if there has been trauma to that particular person, it's hard for them to get out of fawn and realize it's time for me to walk away. So this understanding is really important whenever you're dealing with multiple different types of patients. So that way you're less judgmental and more willing to be open to listening to what they have to say and more receptive. Obviously, there does need to be some psychological care involved in these cases, as well as these people try to become healthier versions of themselves. This article right here, another really good article, So if you're not familiar with complex PTSD, or you maybe want to know a little bit more about how to help these particular people, especially if it's someone in your family that you love, I do encourage you to read this particular article, so that way you can understand from their shoes what they may be going through if you have no idea why they make the choices that they make. All right, so our two divisions of the ANS, what do we call them? Sympathetic and parasympathetic, so that's your fill in the blank. Sympathetic and parasympathetic exit the spinal cord in different regions, and they have other anatomical differences. So the point of origin in the CNS is all about where do they exit the spinal cord. So for the sympathetic, we said that they're going to exit in the thoracolumbar area, okay? So in T or in L. For the parasympathetic, where did we say that that's going to exit the spinal cord? Craniosacral. Okay, craniosacral. The location of the autonomic ganglia is also going to be different. So therefore, because the location of the autonomic ganglia is different, the length of the fibers on that preganglionic and postganglionic neuron are also going to be different. And again, we're going to go through them each individually, so that way you can kind of see where those locations of the autonomic ganglia are. And I have a picture for you coming soon. And then divergence. So make sure you circle that word and you understand divergence means that we have just one preganglionic neuron that can synapse on several postganglionic neurons. And this is mostly going to occur in sympathetic nervous system. Okay, so divergence is a real big deal in the sympathetic system because it happens a whole lot more on the sympathetic side than it does on the parasympathetic side. And what that means is this allows mass activation because there's a lot more synapses and there's a lot more communication between those neurons talking to one another. So you can get more system-wide effects whenever you're in the sympathetic mode than whenever you're in the parasympathetic mode, which is good for emergencies, not good for chronic stress, because that means that mass activation is going to continue to affect you system-wide. So here you can see just a little chart where I've kind of broken down the sympathetic thoracolumbar is going to have short preganglionic and long postganglionic fibers because the ganglia is close to the spinal cord. So that's the way to remember it. For the sympathetic division, that ganglia is very close by. So just think about if you have an emergency, you want something to happen real fast, okay? You want access to something that's real close by. So the sympathetic division, the ganglia are very close to the spinal cord, which gives us the short preganglionic and the long postganglionic fibers. Opposite for the parasympathetic, the ganglia are actually in the visceral effector organs, which is going to give us long preganglionic and short postganglionic fibers. Here's the chart from your book, so you can actually see, if you like this chart better, feel free to use this chart, but basically it says the same things. And then you see down here, degree of divergence. In the sympathetic division, approximately 1 to 32 versus parasympathetic, approximately 1 to 6. So again, that mass activation more likely to occur with that sympathetic side because of the increased amount of postganglionic neurons that the preganglionic neuron can talk to. Okay, so let's look at this picture. So green, this is your thoracolumbar section, okay? Thoracolumbar is which system? Sympathetic, very good. Okay, sympathetic ganglion are close to the spinal cord. So here's your little ganglion right here, close to the spinal cord. That gives us this short preganglionic fiber and the long postganglionic fiber. You can also see here that whenever we're looking at the synapse, the neurotransmitter that's going to be used is acetylcholine in the autonomic ganglion. However, whenever you come this way and you look at the postganglionic axon, now you can see that we've got norepinephrine being used. Okay. In your adrenal medulla, definitely take a note right here. Highlight this word, specialized sympathetic ganglion. Because what you're going to see is that this adrenal medulla, not the whole gland, just the medulla, the middle portion, medulla is the middle. The medulla is actually the ganglion. And this is a very specialized ganglion. There is no parasympathetic innervation to the adrenal medulla. It is purely sympathetic. So you will have the axons that come from about T8 to L1 that are going to go on to innervate this adrenal medulla. And whenever the adrenal medulla is stimulated, it will release epi and norepi in about an 80-20 split. So some books say 75-25, some books say 80-20. So majority epinephrine, minority norepinephrine. Now, circle the blood vessel, okay? Because that means that this response is going to last longer because now you have the hormones that are going to go over into your bloodstream. So the adrenal medulla is very special in the body. The adrenal medulla is that one that will give you that burst of adrenaline if something happens to your kid. This is why moms can pick up cars and they can get them off of their kid. This is the one that gives you that superhuman strength that you don't even think about it. You just go for it. That adrenal medulla will allow you to get yourself out of some very dangerous situations. And so it is very, very important. Unfortunately, the adrenal medulla also gets highly abused because we now live in these high stress situations, and oftentimes we're calling on it to get us through these things that it really shouldn't be used for. So those hormones can get messed up, and it can cause problems in the entire endocrine system because this adrenal gland is a part of your endocrine system. And again, we'll talk about it more in 2402. We'll go in much greater detail with it. Okay, so that's your sympathetic side. Now for parasympathetic, remember cranio, so cranial, sacral, cranial. What you can see up here is we have cranial nerve 3, 7, 9, and 10. These are the cranial nerves that we're going to use in the parasympathetic division in order to help innervate various organs. So you can see long pre, and a short post in order for the parasympathetic division to innervate the visceral effectors. Now, what you also see is acetylcholine is going to be used on both of these synapses. Okay, that's different from the sympathetic, which is going to use acetylcholine, norepi, and maybe even epi. All right, so sacral, that's going to be S2 through S4 in this particular area of the spinal cord that will go on to innervate other structures. Now, this is as compared to your somatic motor system. So remember your somatic motor, we just have one neuron from the central nervous system to a skeletal muscle, and it is going to be using the acetylcholine. Okay, so one neuron pathway, stimulatory effect. Two neuron pathway, this could be stimulatory or inhibitory, just depending upon what's going on in the body at the time, and also depending upon the receptors that are present and how they read the neurotransmitter. So whenever we're talking about the difference between the ANS and the SNS, yes, we have different effectors, because as we've already said, the SNS, the stomatic, is all about the skeletal muscles, and the ANS is the cardiac smooth, the glands, the adipocytes. So yes, we do have two different types of effectors. Then what we also have is the pathways. So this is what we've said. We've got one that will go straight to the skeletal muscle. In order to get to an organ, we need two, the pre and the post. Okay? And then, so there's your autonomic ganglion. The target organ response. So whenever we're looking at the somatic motor neurons, again, the acetylcholine is excitatory. So it is going to cause the stimulation of the skeletal muscle, which will allow it to contract. In the ANS, remember the preganglionic fibers release the acetylcholine. Postganglionic fibers are either going to release norepi or acetylcholine. Epi, if we're talking about the adrenal medulla. And the effect is stimulatory or inhibitory. And so this is the important part. It's all about the neurotransmitter and the receptor. So whatever the neurotransmitter docks with the receptor, that is going to then determine the impact to the effector. So let's look at this really quickly. On our sympathetic pathways, what you can see here is we've got the acetylcholine being released, and we've got what we call a nicotinic receptor. Nicotinic receptor on both of these, sympathetic and parasympathetic. On your post-ganglionic, with that norepinephrine, we've got what's called an adrenergic receptor. However, on the parasympathetic side, we've got acetylcholine being released with a muscarinic receptor. Now, again, this is just introductory stuff, so we're going to go more into the receptors as we go through the individual systems. So this is just to get you used to the vocab, okay? So adrenergic, nicotinic, and muscarinic are the different types of receptors that we'll be talking about. Acetylcholine, norepinephrine, and epinephrine are the neurotransmitters that we'll be talking about. And then this is just another picture. Different people like different pictures, so again, we'll talk about it more in detail later on, but this one will actually show you the short preganglionic fibers for the sympathetic versus the long for the parasympathetic, and they still have the different receptors that are on here. Okay, so I know that's a lot. So what are the two divisions of the ANS? Perfect, sympathetic and parasympathetic. What are the general functions of the sympathetic? What is that going to help us do? Perfect, respond to emergencies, make a run for it. What about parasympathetic? Rest and digest. Good. So we've got fight or flight, rest and digest. What does the ANS control? Visceral effectors. Very good. Visceral effectors. Is the ANS a division of the CNS or the PNS? PNS. Perfect. So ANS is the subdivision off of the motor division of the PNS. The adrenal medulla is known as a, this is what you highlighted. You guys remember? You're about to say it. I thought you were about to say it. Specialized sympathetic ganglion. There you go. Specialized sympathetic ganglion. How many neurons between the CNS and effector in the ANS? Two. Perfect. What are they called? Perfect. Pre and post. Where do they synapse? Did you say autonomic ganglion? Because that's the answer. So yes, in the autonomic ganglion is where the pre and the post are going to synapse. Okay, so the pre will talk to the post in the ganglion, and then the post will talk to the effector itself. Okay, remember this is all about balance. So we need both sides. Both sides are important for us to maintain homeostasis. So since we need both sides, most, not all, see I italicized most. Most organs are under what we call antagonistic control due to dual innervation. So dual meaning both, okay? Both generally go to most organs in the body. In this particular case, you'll have one that will be excitatory and then the other will be inhibitory. So for example, if we're talking about the pupil, think about this for a second. If you are going into a movie theater, you're leaving the 2 p.m. sun to go into a movie theater. It's dark in the movie theater. What is your pupil going to do? Dilate. So that way you can see. Okay, now if we make it an emergency situation, someone is shooting in the theater, obviously your pupil is already dilated, so that way you can have as great a vision as possible, so that way you know, how am I going to get out of here? But let's say there's no emergency situation. Your pupil is still going to stay dilated regardless because it's dark. What happens whenever you walk out into the 4 p.m. sun after you've been sitting in the dark for 2 hours? It'll constrict, all because you don't want that much light going in and damaging your internal eye anatomy. So the pupil can dilate and constrict depending upon what is necessary at the time. If you're in an emergency, you want to be able to see all things around you so that you can figure out the path to get out or the gun to pick up, you know, whatever it is. But whenever you're resting, your pupil is going to constrict because you don't need to have your eyes open like that. You're about to go to sleep. So sympathetic response is going to dilate your pupil and parasympathetic response is going to constrict it. That makes sense to you guys, right? Okay. All right, so if we're looking at this chart, what I want you to see here is I put a little star next to the adrenal medulla because remember, this does not have any parasympathetic innervation. So you've got this little gland in the center of this little gland with purely sympathetic stimulation. So there's no dual innervation here, okay? So there is no way to have an opposite and opposing effect. Now, if you look over here, there's another star. That's because this is skin stuff. So whenever we're looking at, I wrote it down for you, when we're looking at the organs that are innervated only by the sympathetic system, these are the ones that you want to make sure you remember. So we have the adrenal medulla, neurohypophysis, which is basically the posterior pituitary gland, the sweat glands, the erector pili muscles in the skin, and most of our blood vessels. Just sympathetic innervation. Okay, so even when there's no stimuli, the autonomic motor neurons show what we call a resting level of spontaneous activity, and we refer to this as autonomic tone. So circle that word tone. The tone is significant where you do have dual innervation, but it's even more important where there is no dual innervation. So in the areas like the adrenal medulla and in the blood vessels, it's very important that you maintain autonomic tone. So what does that mean? Well, let's take the example of the blood vessel. Blood flow to specific organs absolutely must be controlled in order to meet the tissue demands for oxygen and nutrients. If we have blood vessel dilation, this is going to increase our blood flow. If we have blood vessel constriction, this is going to decrease our blood flow. Okay? We want to be able to have both. because at any given point in time, it is necessary for our body to be able to automatically adjust blood flow to specific tissues depending upon the activity of that tissue in the moment. But there's no dual innervation. So it's not like parasympathetic can do one and sympathetic can do the other. Sympathetic is going to have to do it all in these particular cases with blood vessels. So you'll have the sympathetic postganglionic fibers releasing norepi at the smooth muscle cells in the vessels. And you have this background sympathetic tone that will help keep those muscles partially contracted. When increased blood flow is needed, then the rate of norepi will decrease, and sympathetic cholinergic fibers are stimulated. As a result, the vessels will relax, they'll dilate, and the blood flow can increase. So basically, we adjust the tone in order to affect the activity of the smooth muscle cells in the walls of the blood vessels, since there's no dual innervation. So this can then allow the sympathetic nervous system to have complete control depending upon what is necessary at that particular point in time. So there always has to be some sort of, not stimulation, that's not the word, always has to be some level of activity going on within these cells at all points in time. So that way everything is working appropriately as it's supposed to. And that's what we would then call tone. Okay, autonomic tone, there's always activity. Okay, so when we're looking at the dual innervation says, for instance, we're looking at the parasympathetic division. If we have all of these organs that need to be innervated, but we also need to give them some sympathetic innervation as well, how are we going to do this? Well, in the head, you have these particular ganglia that I circled for you here. You can see these 4 ganglia are going to be the ganglia where the synapse will occur in order to take the innervation to these particular organs that are going to be in the head area. If we're going to need sympathetic innervation, then that doesn't go through those particular ganglia. What that's going to do is that's going to come through what we call the superior cervical sympathetic ganglia. So you can have dual innervation because the fibers can go in different areas of the body in order to innervate the same structures. Remember the craniosacral, that means we have to come from cranial if we want parasympathetic innervation to those head structures, but there is no craniosacral for the sympathetic division. It's thoracolumbar. So what's going to happen is the neuron is going to have to leave the spinal cord and ascend in this string of pearls right here, this yellow string of pearls we call the sympathetic chain ganglia. The fibers can ascend and come up to this superior ganglia and then go on to innervate those same organs. Again, general overview, we're going to be discussing it again. You'll see the difference in parasympathetic versus sympathetic, but I'm just trying to show you at this point in time, how do these fibers, which come from different parts of the cord, actually innervate the same structures, because there is dual innervation in so many organs within the body, and that's how it's actually going to occur. Okay. We also have autonomic plexuses. So remember, plexus is like a nerve network. The autonomic plexuses are going to take care of the thoracic and abdominal pelvic cavities, because I just showed you the example of what happens in the head. So the autonomic plexuses will work by actually mingling the sympathetic postganglionic fibers and the parasympathetic preganglionic fibers. And these are the different plexuses that you can see here. So obviously cardiac is going to the heart, pulmonary to the lungs. The celiac is a very common plexus that is discussed. So the celiac plexus is going to be going into the different organs within the abdominal cavity, as well as the inferior mesenteric plexus. And then for those that are in the pelvic cavity, we have the hypogastric plexus. So here's a picture of those different plexuses here so that you can see the different names, where they're going to go to innervate the various structures in the body in order to give that dual innervation. Okay? So let's take an example of the heart, because the heart receives dual innervation. If we have acetylcholine released by the parasympathetic postganglionic fibers, this is actually going to slow the heart rate. Norepi released by the sympathetic side is going to increase heart rate. So just think about what would normally happen in an emergency. Your heart is going to beat harder, it's going to beat faster, so that way more blood can be pumped out to your skeletal muscles, especially if you're going to run or if you're going to stand there and fight somebody who's larger than you. Now, that is what's going to happen whenever you're in an emergency. If you're not in an emergency, there's no reason for your heart to beat that hard and that fast. So that's why the parasympathetic side will actually slow your heart rate. Remember, small amounts of both are going to be released continuously because there is dual innervation, and this will help us maintain that tone. And at any point in time, we can switch over in order to meet the demands of the body. The parasympathetic, parasympathetic division will dominate at rest. So when we get into cardiovascular in 2402, we're going to talk about the pacemaker of the heart and how it sets the tone for the heart. And you'll hear that that pacemaker normally will do 80 to 100 action potentials per minute. But normal heart rate, resting heart rate, should not be 80 to 100. For some people it is if you're out of shape. But normal resting heart rate should be somewhere between 60, 80, depending upon your age, maybe 85. Well, why then is the pacemaker faster than the actual heart? That's because of the parasympathetic division. So the parasympathetic division will dominate, and it will take over, and it will actually slow the heart rate down. Okay? Of course, crisis is going to speed it up. And it'll speed it up by stimulating those sympathetic fibers, and it'll tell the parasympathetic fibers to stop. So it'll inhibit any activity that says slow the heart rate down, and it'll stimulate any activity that tells the heart rate to speed up whenever you're in crisis situation. Okay? So if we look at this picture here, you can see on our graph our beats per minute. So let's say the heart is at rest, you're at 72 beats per minute. Both divisions are active. All right, so highlight that. They're active. You have autonomic tone. Even though you're at rest, they are still working. They're always in the background working. It's like those computer programs that even whenever you turn on your computer and all you want to do is get on the internet, there's like 1,000 programs that run in the background all the time. So that's what they're doing. They work in the background. So if we increase the parasympathetic stimulation, it lowers the heart rate because we're releasing more acetylcholine to say slow down some more. Okay? If we inhibit parasympathetic, or if we stimulate sympathetic, it's going to cause our heart rate to rise. And then if we have increased sympathetic stimulation comboed with parasympathetic inhibition, then we increase the heart rate to the maximum levels. So your heart rate can't keep going higher, 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 higher. There is physical structures and there are biochemical structures that are going to give it a cap, and we talk about that in 2402. But if you have both the increased sympathetic stimulation and the inhibition of parasympathetic, that's whenever you're going to get your maximum heart rate. Okay, does this graph make sense to you guys? What's happening whenever you have the parasympathetic versus sympathetic? If you take one away or you add one, does that all make sense? Okay. All right, we already know we need to maintain homeostasis. This is going to occur via what we call visceral reflexes. Now, these reflexes don't work alone. There are other components that are going to be a part of this process of maintaining homeostasis. But if we look at the visceral reflexes, that will help us with ensuring that the information is properly being received at the visceral effectors. We'll also say this is coordinated primarily by the hypothalamus and the medulla. So the processing centers in the medulla help coordinate our complex reflexes, because this is where we will have centers that will allow us to do these various functions here. And of course, these things are going to be regulated by the hypothalamus. There's always going to be some feedback control that the hypothalamus is going to provide in order to make sure that this all works appropriately. So for those of you who like pictures, this basically will show you your hypothalamus will help coordinate the things that the medulla is going to be responsible for in regards to your visceral reflexes. This is a chart of the different types of visceral reflexes. So as you can see here, you have less visceral reflexes on the sympathetic side than you do on the parasympathetic side. And the reason why that's important is because whenever you're looking at reflexes, that means it's just that one thing that's going to be responding in that reflex. So like if somebody comes up to me and they tap my knee with the reflex hammer and I kick my knee out, it's just my knee. Okay, my elbow is not going to go out as well. So whenever it comes to the reflexes, remember, it's just that one area. So parasympathetic has more reflexes, which means it's going to be more specific to those particular parts of the body, whereas sympathetic has less reflexes. And what that means is, because there's a higher divergence on the sympathetic side, we go back to mass activation. So as a whole entire system, the sympathetic division can affect our entire body. Okay. All right. In addition to the divergence, also remember, I told you to circle the blood vessel from the adrenal medulla. So that is another reason why the sympathetic can have a system-wide effect, because if the adrenal medulla is stimulated, those hormones go in your bloodstream and then your blood goes everywhere. Okay. So let's talk about this real quick. Let's talk about some fun stuff. Ejaculation in males, you see here, is on the sympathetic. Sexual arousal is on the parasympathetic. And I'm not exactly sure why they put this just in males, because this is also for females, even though it's not called ejaculation, you know, the orgasm. But you see here, sexual arousal is on the parasympathetic side. Sex is something that is good at helping to balance the autonomic nervous system when it's done in a healthy way. I understand there's a lot of people who take advantage of it, but whenever it's done in the way that it's intended, sex is incredibly healthy. And the problem is that there's a lot of discrepancies between, well, she doesn't really want to have sex as much as he wants to have sex. All right. So if we look at the reasoning behind what we've already learned about females predominantly being right-brained, so most females, 90% of them are right-brained, which means they think about a lot of things, they're more emotional in things. They also tend to be more multitaskers, which puts them more over in the sympathetic dominant side, because they're doing so much and they're thinking about so many things, and oftentimes they're just wearing themselves out. So if we take a male who is generally, I just want to do one thing at a time, you know, they don't freak out, they don't get really emotional, they're like bullet points, I mean, just tell me what I'm supposed to do and I'll take care of it. They generally can go over into the parasympathetic side a lot easier because they don't allow themselves to stress out. That's left brain dominant. So if you're dealing with somebody who is a right brain woman, left brain male, if that right brain woman has a hard time getting into parasympathetic mode, yes, there's going to be problems in the bedroom. And so whenever you look at the benefits of sex as a whole, it's very important to be open to discussing this with patients, because it is so healthy and will help many, many people whenever he just learns, okay, I have to do more things to put her over into parasympathetic mode. It's not just a, okay, I'm ready, let's go, and she is too. Because y'all are in two different states of mind, two different autonomic nervous systems functioning at different levels. So if you get more over into the parasympathetic side, Or if you tell your husband, hey, if you rub my shoulders or give me a massage. Massage is great, right? Because massage rests and relax people. And usually massages, they lead to sex. People will be so calm and they'll be like, oh, I feel so great. And that's one of the things to do. Sometimes some people need a little bit more than a massage. But the point is, get over into parasympathetic. Both males and females have to be in parasympathetic for the arousal, for the glands to start flowing, so all of the juices start flowing that are necessary for sex. And then whenever the orgasm happens or the ejaculation happens, that is sympathetic side. So you get both with that one activity. Now, if you're not having sex, there's other things that you can do that will help you to get both. Exercising is that for some people, but that's why I say it's so many people feel like sex is a taboo thing, but it's really a very healthy thing, and it's actually very, very good for our autonomic nervous system to help balance, so that way we get both sides. Because remember, homeostasis is all about how do we balance this and get both. You guys ever heard that phrase? Wow, that person really needs to get laid. Okay, so that's where that kind of comes from. What they should say is you really need to balance your autonomic nervous system. Okay, because that would be more technical, that would be more medical, but yes, it is true. All right, so here's some health benefits associated with orgasm, because I couldn't just let it be on just the reflex chart, right? Couldn't let it go. An orgasm at least once or twice per week appears to strengthen the immune system's ability to resist flu and other viruses. My, how many people do we need to let know this right now during the time of COVID? Like, you know what? I got a good idea for you to increase your immune system. And no, it's not take vitamin D, although that's good too. So yes, that is something that is great. Pain relief, also great. Especially whenever women have the ability to release the orgasm, because of the chemicals that are released with that will help with alleviating some of those muscle contractions. And then better sleep is by far my favorite one. It's good stuff all the way around. All right, so if we go back to those reflexes, whenever we're talking visceral reflexes, these are autonomic, polysynaptic reflexes. So there are things like the monosynaptic reflexes, which would be like what I just did to my knee, but these are polysynaptic reflexes. They can be modified, facilitated, or even inhibited by the higher centers, especially the hypothalamus. So the hypothalamus can make changes because the hypothalamus is really going to run a lot of things that occur within this ANS here. So the reflex arc is very similar to the reflex arc that you guys have already seen in the past. It starts with the receptor, just as in the past we started with the receptor, then the sensory neuron that's going to take the information in, the processing center, all of that is the same 1, 2, 3. Now what's different here is instead of just having that one motor neuron, now we have those 2 visceral motor neurons. And there's another difference. They can be long or short reflexes. So if we look at this picture, you can see if it's a long reflex, then that means that it's actually going to have to go into the CNS. A short reflex will bypass the CNS. It doesn't need to use the central nervous system because it goes straight to the autonomic ganglion, okay? So we don't have to go in through the dorsal root and then get into the horns and then go to the ganglion. Short reflex will bypass it completely to go straight through.
Where is the ENS in all of this?
Good question, Ann. It's coming. You're like 2, 3 slides ahead. Okay? All right. So whenever we're looking at our short versus our long, just make sure that you remember your long reflexes will coordinate the activities of the entire organ. Okay, remember they do need to use the CNS, so they will go through those posterior roots. Short reflexes bypass the CNS. And what we're looking at here is activity in one small part of an organ, not the entire organ, just a small portion of the organ. Okay, for our long reflexes, this is where we're going to see in most, but short reflexes, this is where we're going to get into the ENS. Okay, so short reflexes are mostly going to be within the digestive tract and then the glands within. So for our ENS, if we're looking at this, what you can see is this is a drawing of your GI tube. Okay, so your tube extends from your mouth to your anus. And your tube, what you can see, has multiple layers. So there's multiple layers of muscles, and I won't get all into it because we do in 2402. But what I want to point your attention to are these yellow structures that you see here with the enteric plexus and the submucosal plexus in the orange. So these are your nerve networks. And you can kind of see them over here as well, submucosal plexus and enteric plexus. So these are going to be, as you can see, the little bulges or the little bulbs here. You have ganglia in the walls of your GI tract that will contain the cell bodies of the visceral sensory neurons, the interneurons, and the visceral motor neurons. And you've got these extensive nerve networks that are capable of controlling these digestive functions without CNS input, okay, which we know makes the ENS very cool. So the plexuses are going to detect what's going on within that tube, no matter whether it is at the very beginning of the tube or the very end of the tube, whether you've just eaten something or whether you need to poop something out. The plexuses will change what's going on within that GI tube as necessary in order to maintain that homeostasis. Unless you're in the super sympathetic dominant state, of course. Okay, and again, we talk more about all of that in 2402. Okay, so let's do some review questions. What is a visceral reflex? Visceral reflex, autonomic reflex initiated in the viscera. Okay, the automatic motor response. Remember, it can be changed by the hypothalamus. Would a tumor in the hypothalamus cause problems in the ANS? Yes, absolutely. Because the hypothalamus has so much control and so much say, it will cause some major issues. Okay, so if we're talking divergence, what's the difference in the amount of divergence in sympathetic versus parasympathetic? Which has more? Sympathetic has more. So what does that mean that sympathetic has more? What's the significance of more divergence in the sympathetic system?
Your whole body?
What'd you say?
It's your whole body?
So the whole body is going to be affected, right? Mass activation. So we're going to have mass activation occurring in your sympathetic system because there is a higher degree of divergence. Okay, more complex, more coordinated responses system-wide. So, like I said, next class we're going to talk about the parasympathetic system, and we'll go into that in more details.